Okay, let's start. Hello, everyone, esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2023. My name is Wiktoria Śliwka, and I have an honor of moderating a surgery session. I would like to cordially welcome the esteemed jury, president of the jury, Professor Beatę Jabłońską, and members of the jury, Dr. Ewę Gruzińską. Okay, and we would like to explain to you the rules of the session. The order of the presentation will be the same as in abstract book. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind that if you are the supervisor of the paper which is present, you should not access the work. In that case, please cross out the number of the card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. I would like to remind that if the work is presented in English, the discussion also should be run in English. If the commission will ask the question in Polish to you, the author of the work are obligated to answer still in English. If the discussion is run in Polish, the additional point for speaking in English will be not count. And we kindly ask the jury to assess scientific value, way to presenting, discussion, own contributor, and 0 or 1 point for presentation and discussion in English. When the session ends, we kindly ask you to give the cards back to the coordinator, so back for me. And please send information for jury online, but now we don't have any. So maybe let's begin. I would like to ask to present first presentation. It's online presentation, so Krystyna Markniewicz, are you here?
Yes, hello.
Okay, you can start.
Okay, thank you. Hello, everyone. I hope you can see my presentation and you can hear me. I'm Krystyna Markniewicz, fifth-year medical student, and today I'm going to present a work entitled Self-Locking Polymeric Lips are a safe option for appendiceal stem closure in laparoscopic appendectomy. And the supervisor of the study is Professor Tomas Poškus. Appendicitis is a common surgical cause of acute abdomen and affects more than 200 people per 100,000 people every year. The diagnosis of acute appendicitis has increased during the last 30 years due to better diagnostic tools. Therefore, the financial cost for it also rise. As we know, laparoscopic appendectomy is the gold standard of acute appendicitis treatment, and appendiceal stem closure is the most critical step in the operation. And there is a variety of technical methods reported in the literature, such as polymeric lips, loops, echelon staplers, and others like harmonic scalpel, titanic lips, or the others. But despite appendectomy being a daily procedure in the world, everyone uses different types of methods for appendiceal stem closure. So the best one is still not identified. In this study, we focused on the comparison of those two methods, polymeric lips and loops, and we aim to evaluate the effectiveness of those two methods for appendiceal stem closure. We got the permission for retrospective analysis, and we included all patients who were presented at Vilnius University Hospital Santaros clinics from June 2016 to April 2021, and who met the inclusion criteria. They should be adults with acute appendicitis diagnosis, and they should underwent laparoscopic appendectomy. Then those selected patients were divided into two groups, clips group if polymeric clips were selected, and loops group if podes or Becquerel loops were used for appendiceal stem closure. Then we selected all those patients' data that included demographic characteristics such as sex and age, also operational features, as I have mentioned, the method for appendiceal stem closure, clips or loops, also post-operative outcomes such as hospitalization time, complications after the operation, and the histological findings, as well as the price of the different methods for appendiceal stem closure. And in the end, we analyzed the data in the statistical software package R version using Pearson Heath square test, Wilcoxon-Rankin test, and Fisher exact test. Let's go to the results part. At first, we identified 654 patients with acute appendicitis, but from them, 112 patients were not included into the study because they were treated conservatively. Then 542 patients underwent operation, but from them, 27 were excluded due to open appendectomy because of the conversion after the complicated laparoscopic appendectomy. And in the end, we got 515 patients who underwent laparoscopic appendectomy. And as I have mentioned before, they were divided into two groups, clips group and loops group. And as it is retrospective analysis, our study had no impact on the assignment of patients to one or another group. As we can see from the table, there is no statistically significant differences between the groups in sex, age, or histological findings if we look to p-value. The second table presents the outcomes of the groups, and there were also no statistically significant differences in outcomes between the clips group and the loops group, and the 30-day complication rates were low at 1.8% in clips group and 1.6% in loops group. And we also calculated the hypothetical costs of the procedures. In our hospital, we use 3 polymeric clips and 1 laparoscopic appendectomy, while 5 clips and 1 unit cost €7.69. So the same price per one operation. Or we use 3 Becquerel or podes loops, which are packaged one at a time, and one loop costs from 30 to 32 euro. So per one operation, from 91 to 96 euro. And if you use echelon stapler, so the price for appendiceal stem closure is more than 500 euro. And we found out that self-locking polymeric clips are 12 times cheaper than Becquerel or podes loops, and almost 67 times cheaper than echelon stapler. However, there is no consensus on the technical method in the literature for closing the appendix stem. And based on the recommendation, if the whole appendix cannot be visualized, the clips or stapler should be selected. And if the appendix is fully mobilized, clips, loops, or stapler can be all used, and it just depends on the thickness of the appendix base. But if the base of appendix is inflamed, according to the data in the literature, stapler is the best choice for appendiceal stem closure. However, a recently performed meta-analysis shows that loops and staplers are equally safe for appendiceal stem closure, and there are more and more clinical trials in recent years that present that all 3 options, clips, loops, and staplers, are equivalent in terms of post-operative complication rates. And while self-locking polymeric clips are a less prevalent option in laparoscopic appendectomy for stem closure and are more used for the closure of bleeding vessels or tissue structures, they were also proven to have advantages. They are cheap, safe, it's easy to use, and they were also associated with a shorter operation time. To conclude, the use of polymeric clips and loops is equally safe and effective choice for appendiceal stem closure. and the complication rate was neither clinically nor statistically significantly different between those two groups. And in addition, polymeric lips was the cheapest choice for appendiceal stump closure. And in the end, I would like to send a take-home message that the routine use of polymeric lips in laparoscopic appendectomy reduces costs while maintaining good postoperative outcomes. There are my references, and thank you all for the attention. Do you have any questions?
Thank you for your presentation. I would like to remind you that all of you can ask some question for participant. Of course, first of all, our jury.
Thank you for a very good presentation. Congratulations of the large group of your patients. I have some questions. What were criteria for selection of the methods of appendix stump closure? Who has decided about it? How could you explain the big difference of the number of patients in between clips and loop groups? And the second question is, what about operating surgeon? Were these procedures being performed by the same surgeon, specialist in surgery, or resident? And the last question is about your contribution to this work. You are the only author of this presentation. I have found a full text paper published in the journal Medicina. In this paper, identical data are presented, and there are 4 authors of this work. Thank you.
At first, thank you very much for those questions. To begin, when laparoscopic appendectomies were introduced in Lithuania, polymeric lips were used to close the appendiceal stump as a standard, and they are still applied as a standard in our hospital today. And the choice of using polymeric lips or loops depends only on operating surgeon. Your next question was about the person who operated. We have at some point a limitation of the study because we didn't detect the operation time, because we feel that it could be different when operation is performed by residents or by experienced surgeon, and as it wasn't performed just by one surgeon, we didn't take the operation time, and we didn't detect which exactly surgeon performed the operation. And talking about the publication, yeah, there were 4 authors. Thomas Poškus was the supervisor of the study. I selected all the data, watched some of the operations, and Eugenis Jesunas was the person who helped with the statistical part. And Raminta Lukštaitė was mentioned because she is a radiologist, and she was one of the person who made an abdominal ultrasound and diagnosed those appendicitis. Is there more questions that I haven't mentioned?
For your answers. Concerning your results and retrospective nature of your paper, I would recommend to perform prospective randomized study in future. Thank you.
Thank you very much for your recommendation. You will think about that, and I guess we will do that. Thank you.
Congratulations, Christine, on your presentation. I only have one question about the complications. Do you have any record what kind of complications your patients experienced? Were they directly connected to the type of closure of the stump, or were there any other complications, for example, related to the laparoscopic access or any other kind of complications?
Yes, we have recorded the complication, and because of the lack of time, I haven't mentioned them in the presentation. We got one complication in Lopes group that was postoperative fever, but the histological diagnosis of that appendicitis was perforated one, and we have 8 complications, patients that had complications in CLIPS group, and there were 2 of them had postoperative fever, one wound infection, and some of them had intraperitoneal, intra-abdominal abscess. And we don't think that it was related to the method that was chosen for appendiceal stem closure, and maybe it's more on the appendicitis, because almost all of them that were complicated was perforated or gangrenous appendicitis.
Okay, Christina, I need to end this discussion. Thank you for your presentation. And I would like to ask to present the paper Pancreatic Solid Pseudopapillary Neoplasms, Clinical Pathological Characteristics by Agnieszka Partyka.
Good morning, everyone. My name is Agnieszka Partyka, and I am going to present a work which is called Pancreatic Solid Pseudopapillary Neoplasms, Clinical Pathological Characteristics. Here we have a brief presentation plan. Pancreatic solid pseudopapillary neoplasms are rare tumors that are predominantly affect young women in their 2nd or 3rd decade of life. The etiopathogenesis of SPN is unclear. These tumors are of low malignant potential with rare metastasis occurrence and are associated with good prognosis. They make up to 1% of all tumors of the pancreas. As I was saying, these tumors make up to 1% of all tumors, pancreatic tumors, and 3% of cystic neoplasms of the pancreas. Surgical resection results in long-term survival in most patients. However, these tumors can become considerably large before causing any symptoms, and that is why are mostly asymptomatic accidental findings. SPNs are frequently located in the pancreatic head or tail and are often misdiagnosed. Our study aimed to present and analyze clinical pathological features of solid pseudopapillary neoplasms of the pancreas. We retrospectively reviewed 24 patients' clinical data who underwent pancreatectomy in the Department of Gastrointestinal Surgery in Katowice between 2014 and 2023 and were diagnosed with SPNs. We excluded 2 patients due to uncertain histopathology results. The mean age of patients in our study group was 34 years with a standard deviation of 11.09. The group consisted of 21 women and 1 man, and the percentage of women was 95.45%. So the significant predominance in females was observed. In our study group, 8 patients had normal BMI, 5 were overweight, and 8 had various degrees of obesity. Okay, 14 patients, meaning 63.64% in our group were asymptomatic. 8 presented with symptoms such as abdominal pain, abdominal discomfort, bloatedness, constipation, loss of body weight, nausea, vomiting, and asthenia. 16 patients, so 72 6.73% had comorbidities. Most common ones were arterial hypertension, brachialgia, asthma, depression, hypercholesterolemia, and hypothyroidism. Patients underwent different types of surgery. 20 patients had pancreatectomies. Amongst 27.27% had pylorus preserving pancreatoduodenectomy, also known as transversal Longmire procedure. 13.64% had central pancreatectomy, and 50% had distal pancreatectomy. One patient underwent duodenum preserving pancreatic head resection, and one had tumor aneuploitation of pancreatic uncinate process. The median duration of surgery was 5 hours and 12 minutes, with minimum 2 hours 20 minutes and maximum 9 hours 13 minutes. Most of the patients were categorized as group 2 in the ASA scale, and a majority of surgical resections was classified to to R0 group in the residual tumor classification. In our study, tumors were located in different parts of pancreas, mostly in the pancreatic body, head, and tail. The median size of tumors was 3.6 centimeters with an intercratal range equal to 4.43. Histopathology showed features like perineal invasion, pseudocapsule, resorption, hemorrhage, vascular invasion, mucosal metaplasia, hyalinosis, infiltration of the pancreatic parenchyma, necrosis, calcification in the capsule, or lobular metaplasia, which led to the diagnosis of SPN. Marker of proliferation, Ki-67, didn't exceed 7%, and in one case, metastasis to a lymph node has been found. Most of the patients were classified to PT3 and 0 group in the AJCC staging, and none of the patients required adjuvant therapy. Complications were observed in 13 patients, meaning 59.09%. Most common ones were fever, fluid collection in the post-operative wound, leukocytosis, and pain in the wound area. In 2 cases, reoperation was required due to grade C pancreatic fistula, and clinical suspicion agreed with histopathological examination results only in 10 out of 22 cases, meaning 45.45%. In conclusion, pancreatic solid pseudopapillary neoplasms most frequently occur in young females. Majority of cases are asymptomatic accidental findings. Clinical suspicion is often misdiagnosed, and the final diagnosis of SPN can be based just on analysis of histopathological examination results. Thank you for your attention, and if you have any questions, feel free to ask.
Thank you very much. Let's start the discussion. Maybe for your jury.
Thank you for your good presentation. I have 2 questions. What was your contribution to this work? And have you compared your results with the literature data?
Okay, so we collected all the data from electronic and paper patient's history, and then we performed analysis, which we intend to publicate in the future with a follow-up.
And thank you for your question. And yeah, we did compare the results, and it shows that the predominance in female is observed in our work and the other clinics' works. It shows as well that the most common surgery operation is distal pancreatomy, as in ours. The mean age of women was around 30 or even a little bit lower, but our group is not as big as other ones. What else? Yeah, I think that the most of our studies similar as in others. Thank you.
Congratulations on your beautiful presentations. I have a question. Do you have a record? Do you know what were other suspected diseases? Because you said that almost half of suspected diseases were different than the histopathological result in the end. And the second question, a lot of patients were asymptomatic. So did you compare, for example, whether the location of tumor was different between patients with symptoms and asymptomatic? Was there any correlation between location and the symptoms or no? Because it may be a factor which causes it.
So thank you for your question. Other suspicion for 6 patients was neuroendocrine tumors. For 2 patients, it was gastrointestinal stromal tumors. And in one case, it was a pancreatoblastoma, pancreatic head tumor, and serious cystodenoma.
I would like to answer the second one. So we compared the location and the asymptomatic and the symptoms, and there was no correlation. I guess it's because due to a small study group, and we need to expand it, so there will be more statistically significant, significant correlations. Right. Yes, exactly.
Okay, thank you very much for your presentation and discussion. Tak. Jako druga. Tak jak leci. Dokładnie. Okay, so our third presentation today, presented by Jan Ramjan. The title is Analysis of Early Postoperative Outcomes Following Surgical Treatment of mucinous cystic neoplasms.
Greetings, I'm Jan Ramjan, and I wish to introduce you to our work, Analysis of Early Postoperative Outcomes Following Surgical Treatment of Mucinous cyst neoplasm and their clinical-pathological characteristics. So, for the very basics, let us lean on existing knowledge. Mucinous cyst neoplasm, or MCNs, are rare tumor of pancreas that affects mainly women in their 4th and 5th decade of life. They're localized mostly in the tail of the pancreas. Their etiology is mostly unknown. They have presented the ovarian stroma in most of the time of the cases, and these lesions are benign. However, when left untreated, they may transform into a cancer. In our study, we have included 43 patients that underwent surgery in the Department of Gastrointestinal Surgery in years 2014 and 2022. We retrospectively analyzed the patient's medical history regarding their comorbidities, their clinical symptoms, the type of the surgery, and their laboratory tests, among other data. We applied this Sperman rank coloration coefficient to calculate the correlation between lesion diameter and the type of the dysplasia. Also, we calculated odds ratio and risk ratio of cancer detection in the relations of the NCN diameter. So, we had 43 women in our study whose average age was 46 years old. The most common comorbidities were arterial hypertension and hypothyroidism of 5 cases each. And the median length of the hospitalization was 11 days, and it was a day longer for the patients with complications. As for the surgery itself, it was overwhelmingly a distal pancreatotomy, with 2/3 was performed with splenectomy. The other 2 cases were inoculations of the cyst. The average time of the surgery was 252 minutes, and the median intraoperative blood loss was 300 milliliters. As for the complications, they occur in 51% of the cases, and there were primarily the pancreatic fistula in 42% of the cases, 11 examples of intra-abdominal fluid collection, 3 examples of hematoma, and isolated cases of wound infection and pleural eponema. As for the fistula, half of them were type A, which is an insignificant biochemical leak, and the other 50% were type B that required symptomatic treatment and the drainage of operated area. As for the tumor itself, it was primarily localized in the tail of the pancreas, followed by the body, and there were also 9 cases of it being in body and tail. In our study, the median diameter of the cyst was 6 centimeters. As for the type of dysplasia that we have found out in our study, it was most common the high-grade dysplasia, consisting of carcinoma in situ and cancer, and 7 cases of cancer itself. We have found out borderline statistically insignificant weak correlation between diameter of the cyst and type of dysplasia. And in these 7 cases of the cancer, 6 of them were high grade and only 2 of intermediate grade. We applied the Spearman's correlation coefficient between diameter of the cyst and the cancer detection, and it was a moderate correlation. As for this odds ratio for the cancer and high-grade dysplasia to the diameter of the lesion, there was no significance, but there was a 12 times more likely chance of detection of cancer in the cyst above 6 centimeters. As for the other histopathological features that was found out during the study, the most common was inflammatory infiltration in 53% of the cases, followed by the fibrosis, canalizations, and calcifications. The metaplasia was observed in 56% of the cases, and the most common one was lobular ductal. The ovarian stroma was present in only 26% of the cases. So to conclude everything up, the postoperative complications following the MCN operations are rather common. However, one of the most common is clinically insignificant biochemical leak. The high-grade dysplasia is detected in more than half of the examined MCNs, and there exists a moderate correlation between the diameter of the MCNs and invasive cancer detection. Also, the risk of cancer detection is greater in MCNs above 6 centimeters, albeit the risk of the high-grade dysplasia was similar regardless of the diameter. And this aligns with the guidelines that state that the cyst should be operated on when it exceeds 4 centimeters, as to avoid the transformations into the cancer. Thank you very much. Now I would gladly answer your questions.
Okay, and dear jury, do you have any questions for our participant?
Thank you very much for your very good presentation. I wanted to ask you about the guidelines and your results, but you have already answered this question. So I am asking about your contribution to this work, and it's enough. Thank you.
Well, my personally or the whole group? Well, my personnel was the overseeing of the whole procedure, collecting the data and performing the simple statistics. My colleagues were taking care of the odds ratio and risk ratio of this presentation.
Thank you for the presentation. I have one question. Some patients underwent splenectomy and some didn't. What was the reason for that? Why some patients had a splenectomy and why some of them didn't have it? Do you know the technical reason or oncological reason for that? It's a bit advanced because it's, you know, knowledge of the surgeon, but
no,
I was just wondering if you...
I'm not entirely certain, but
okay.
it was probably most likely due to the placing of the cyst that required a splenectomy.
Okay, thank you so much.
Yes, of course, but wait.
Thank you so much. What is the cause of higher predominance in MCN in women? Could you explain? Thank you.
The data is uncertain. However, it is most likely linked to the estrogen, which would explain why there is the ovarian stroma. And in most cases, there are estrogen receptors found out in the histopathological examination of the cysts.
Okay, so thank you very much for your presentation. Okay, and now please welcome online participant Paula Venkut will present for us her presentation about correlation between time for diagnosis to surgery and survival in laryngeal cancer.
Good morning, everyone. Today I'm going to present, I am Paula Venkut, and today I'm going to present a study done together with Mantas Žemaitaitis about the correlation between time from diagnosis to surgery and survival in laryngeal cancer. Our work's tutor is Evaldas Padervinskis. 1/3 of all head and neck malignancies are laryngeal cancers, which may be a significant cause of morbidity and mortality. Patients are usually men with a current or previous tobacco smoking history, and typically treatment options depend on the disease stages. The focus of laryngeal cancer management over the past few decades has been on preserving laryngeal function without compromising survival, but surgery still remains the primary treatment method. Here on this diagram, we can see number of new cases of laryngeal cancer each year in Lithuania. The growth of new cases could be explained by the development of medicine and better diagnostic tools. And on average, 6 per 100,000 residents of Lithuania are diagnosed with laryngeal cancer each year. In the healthcare system, the length of time between diagnosis and treatment initiation is crucial. This is especially important for cancer patients. And according to the literature, treatment should preferably begin within 30 days of the diagnosis. For instance, the article published in the United States in 2020 discusses the impact of time between diagnosis and surgery on survival in patients with head and neck cancers. And according to the study, treatment was initiated on average 33 days after diagnosis, and the 30-day delay in treatment increased the risk of mortality by 4.6%. So based on that, we hypothesize that the survival rate of patients who received surgery from larynx cancer within 30 days and those who received treatment later should differ. And that was the aim of our study, to evaluate and compare the survival of patients who received surgery for laryngeal cancer within 30 days and of patients who received the treatment later. This research data was obtained retrospectively. We selected patients who were treated in the Department of Otorhinolaryngology, Lithuanian University of Health Sciences Kaunas clinics from larynx cancer with surgery in 2019 and 2022. Information about deaths was obtained from Lithuanian Institute of Hygiene, And 2023, January 1st, was the last date for which mortality information was included. And there were a total of 161 patients, and we can see incidence rate each year in the diagram on the left. 95% of the patients were male, and the mean age was 63 years old. The youngest patient was 42 years old, and the oldest was 84 years old. The mean hospitalization time was 16.68 days, and the mean time from diagnosis to the surgery was 66.16 days. As we can see in this diagram, more than half of the patients were diagnosed with early stage cancer, so stage 1 or stage 2. 1/5 of the patients were diagnosed with locally advanced stage or stage 3, and about 27% were diagnosed with stage 4 cancer, 4A or 4B, but there was no patients with stage 4C cancer or metastatic cancer. Our patient survival rate was 78.3%, but only 42.9% of patients underwent surgery within 30 days of being diagnosed, and 57.1% received treatment later than 30 days. But there was no statistically significant difference in survival between those two groups, between the groups treated within 30 days and those who were treated later. So to conclude, in our study, there was no difference in survival between those who received laryngeal cancer surgery within 30 days and those who were treated later. But to make a reliable assumptions, this study should be continued in order to have a bigger study sample. And there are my references. That's all. Do you have any questions?
So let's start the discussion.
Thank you for your very good presentation. I have a question concerning the other factors that could impact on survival. Did you check the status of human papilloma virus? Because, for example, in oropharyngeal cancer, much better survival, including overall survival and disease-free survival, is associated with the positive human papilloma virus. Could you check the other treatment, for example, the pre-operative radiotherapy or post-operative radiotherapy? And I'm asking about the survival, because you only analyzed the overall survival, but what about the disease-free survival? Did you check it?
Thank you for your question. Question about human papilloma virus. So we don't have that information. We didn't include it in our study. And about pre-operative chemoradiation or radiation. So these all patients didn't have pre-operative radiation, and some of them had post-operative radiation, but we didn't separated them. We just...
what about the disease-free survival?
Excuse me, could you repeat?
You analyzed overall survival, but
Yes.
What about disease-free survival?
No, we only evaluated overall survival.
I have a question. What was the follow-up? Because I can see that you analyzed patients who were operated on, between 2019 and 2021? And when did you check the deaths? Was it 2023? So 2 to 3 years of follow-up, or?
Yes, it was 2023 January.
Okay, and what was the reason for the prolonged time to surgery? Did you analyze the factors which caused the delay in surgery? Because you said that 30 days is the recommended time.
Yes, there were few reasons. I think one of the main reasons was COVID-19, and during that there was some difficulties like to get the treatment as fast as they could, because yes, there was delay in like some tests like computer tomography, biopsy, and yeah, the biggest delay was in COVID-19 and the quarantine. Yes.
And finally, what's your contribution to this work?
Me and my partner Mantas, together we collected the data, and I did the statistics.
Okay, Paula, thank you for your presentation. And now I would like to ask that Kritita Kalita is here with us online in Zoom platform. Hello, Kritita. Do you hear us? Okay, so the next presentation, sixth presentation presented by Magdalena Górska. Title of her presentation is Pancreatic Cystic Neoplasm, Clinicopathological Characteristics.
Dear chairmen, ladies and gentlemen, my name is Magdalena Górska, and I would like to discuss the serious cystic neoplasm group of pancreatic lesions. The main aim of our study was to examine the medical records of 60 patients whose post-operative histopathological reports concluded SCN, and evaluate the clinical and pathological characteristics of this type of lesions. Let me outline the group first. So the vast majority of lesions are benign, with only a few case reports of a malignant variant being serious cyst adenocarcinoma, not present in our patients. SCNs usually represent 10 to 16% of all resected cystic pancreatic tumors. Moreover, the neoplasms are characterized by cuboidal epithelial cells that produce a watery fluid. Usually, they do not produce mucin or communicate with a ductal pancreatic system. And as presented on the slide, there are 5 groups in a literature, described in a literature, in the macroscopic versions of the CNS. which is microcystic, microcystic, oligocystic, mixed, von Hippel-Landau associated, as well as solid. Our study analysis suggests that SCNs can usually be found in women in their 50s, with the mean BMI being 26. Moreover, 73% of our patients were asymptomatic. Therefore, the lesion was detected incidentally during the diagnostic procedures for an unrelated process. When present, symptoms were usually vague and caused by mass effect. Most of them contained the abdominal pain, discomfort, and gastric disorders of various kinds. That being said, SCNs can grow to enormous sizes. The median tumor diameter was 3.5 centimeters and was located more frequently in the body of the pancreas, as presented on the slide. Only 3% of our patients admitted to regular alcohol drinking, and 15% of patients routinely smoke cigarettes. Furthermore, from comorbidities, the most frequent was hypertension, nearly 37%. With that in mind, most of patients had ASA score equal to and NRS score equal 0. Additionally, this slide presents the distribution of a pre-surgical laboratory results for both women and men. As stated, the hemoglobin level was below the norm in most cases, whereas the white blood cells were elevated in most cases. Also, the platelet count was elevated in 36% of women, and CRP in nearly 87% of the female part of our group, and 71% in men. The protein level was below the norm, mainly in men. However, nearly 60% of women presented lower albumin levels. Serum amylase was within the normal range and more or less evenly distributed. As mentioned already, we had no serious cyst adenocarcinoma in our study group. Those most histology results concluded serious cyst adenoma with either micro or oligocystic characteristics. There was also the case, interestingly, there was also a case of coexisting SCAA and IPMN. And the resection for all collected tumors was R0 with no metastasis in lymph nodes or distal parts. The fundamental examination for classification for surgery was CT. In addition, we grouped the types of surgeries as presented, and distal pancreatectomy was the most popular. We also had a case of 3 blood transfusions, and the median required surgical time was about 235 minutes for all methods. Lastly, the predominant complication was pancreatic fistula, with type B being the most common. There was an intra-abdominal fluid collection or an abscess in 10% of patients. And the other complications not mentioned here were, for example, diabetes in a post-operative course. Therefore, the median hospitalization length was about 10 days. The next aspect was reoperation, which occurred in 5 patients. The reasons for each case and the management of them are presented in a table on the right-hand side. And similarly, the rehospitalization arose in 11 patients between 4 and 47 days, also presented on another table. After elaborating on the presented clinical and pathological characteristics, we tried to find a link between them and post-operative complications. However, we found none. The only correlation we found was the lower albumin level, and the potential correlation was the lower albumin level and the complication occurrence. In conclusion, SCN is a symptomatic benign lesion, usually found accidentally in women. The most frequent tumor localization was the pancreatic body, with the median size of 3.5 centimeters. Tumors present themselves, which present themselves usually with symptoms, are an indication for surgery. The most common technique was distal pancreatectomy. And for future reference, there might be correlation between lower albumin levels and post-operative complications. However, we need a bigger data to confirm this hypothesis. Thank you. If you have any questions, we're more than happy to answer.
Thank you, Magdalena, for your presentation. And some questions for you.
Thank you very much for your very good presentation. I have some questions. What was your contribution to this work? This is the first question. Have you compared your results with the literature data? And what diagnostic examinations were performed before surgery in your patients? And how do you think, what would be the reason between the correlation between the albumin level and complications rate? Thank you.
Okay, my contribution to this work was to done statistics. I've done statistics, and my colleague here, Magda, gather data and do rest of the stuff. Your next question was if we compare the data with the literature. Yes, we did, and it was very similar to the recent studies. As Magda said, the tumor are usually found in asymptomatic women in their 50s, and the most frequent tumor location is pancreatic body. However, in the Charles Galani study from 2007, he found out that the tumor were evenly distributed in his data, and he reported one post-surgical death, whereas we had none. And could you repeat your next question? Okay. We think that the albumin here plays a crucial role because it is a status of it is a nutritional status, and based on our results, this should be considered first. Computed tomography was the essential examination before surgery because it can exclude the infiltration of big vessels. Other methods like MRI or ultrasonography was to determine the nature of the tumor and to perform differential diagnosis.
So my question is that you said that 73% patients were asymptomatic, and at the same time, asymptomatic SCNs usually do not require surgery, just watch and wait. So did you find the reasons for qualifications for surgery in these patients? Why were they operated on, or is it just?
We are not certain because of the inconsistence of the data we gather from the hospital results.
Okay, and another question, 2 patients underwent total pancreatectomy for this, well, benign tumor, as it turned out in the end. So do you know what was the reason for total pancreatectomy in these 2 patients? Because it seems like a little bit like over-treatment.
It could be a malignation because all of the tumors we have found were benign, but the doctors may think that there is some stage dysplasia or something like that.
Yeah, exactly. I think that in that two cases, the doctors weren't sure about the nature of the lesion, as CT showed different images every time, and there was some kind of uncertainty, and the patient had symptoms, such as weight loss and abdominal pain. So I think that was the main reason why.
Thank you very much for your presentation, for the discussion. And now let's start presented seventh of today's presentation, presented by Jakub Ciesielka. The title is Should Age Be a Limit? Outcomes in geriatric patient undergoing
So, dear committee, me together with my team would like to answer a question: should age be a limit in terms of outcome in geriatric patients are undergoing pancreatoduodenectomy for pancreatic cancer? As we know, pancreatic cancer is currently the fourth most common causes of cancer-related deaths, and only surgical treatment can ensure radicality of treatment and can contribute to long-term survival in that group of patients. So look in the future, and here arises one question: what year 2030 bring? So it's for 7 years, so we need to analyze this. As we know, by 2030, pancreatic cancer is set to become the second most common cause of cancer-related mortality. And as you can see, on that chart, the trend is still increasing, and by 2030, 70% patients will be diagnosed in older population cases of pancreatic cancer. As you can see on the internet website, numerous identified websites by us promote the choice of treatment according to age. The world age falls hundreds of times, and that is very confusing because it can lead to select the non-optimal treatment for our patient. So is an age and risk factor? We also collected the data from literature that can show us that elderly patients has statistically worse prognosis for older patients, looking to the age cutoff. So what's the aim of our study? The aim of our study is to examine the effect of an age as a potential prognostic factor on the risk of developing post-operative complication in patients undergoing pancreatoduodenectomy. So our medical records of patients who underwent pancreaticoduodenectomy between 2016 and 2022 were extracted. Next, we use inclusion and exclusion criteria, and next, we analyze clinical data, as you can see on that chart. So we also evaluated anthropometric data, type and duration of surgery, laboratory and histopathological results, comorbidities, and medication use, and finally, the post-operative complication. Our patients were divided into two groups, under 70 and above 70 years, respectively. The differences between groups were evaluated using chi-square test, test student test, or Cruxal-Wallis test wherever applicable. As you can see on that chart, of the 134 analyzed patients, men accounted for 55% of patients and women for nearly 45% of patients. Median age of our patients was 64 years. And here's the really important information that patients over 70 years was accounted for nearly 21% of all operated cases. risk related to complication or death was assessed according to ASA scale, American anesthesiologist scale. Our results, patients from the older age group had significantly higher ASA scores, and a pancreatoduodenectomy according to traversal method was performed in 81 patients and in 53 patients using Whipple surgery. Our intraoperative complication, as you can see, occurred in 7 cases, with arterial hemorrhage were the most common. Post-operative complication occurred in 32 cases, where intra-abdominal fluid collections were the most common. As you can see on that chart, patients in elderly group in this cohort over 70 years have significantly higher CCI score, but as you can see on that data, just like duration of surgery, blood loss, complication during procedure, duration of hospitalization in surgery, or also intensive care unit admission, post-operative complication, reoperation, that data did not differ between the groups. Also, the frequency of individual TNM feature staging was comparable between our groups. So our data do not confirm previous findings in literature of an overall higher incidence of complication in the elderly population. We strongly believe that a better parameter of preoperative risk is physical status, comorbidities measured by ASA scores. So which factors should be considered during qualification for pancreatoduodenectomy? So BMI, comorbidity index, ASA scores, stage, types, and grades of pancreatic cancer, and also resectability criteria. We should always remember about that. The medicaments that patients use, or and also laboratory parameters. So to conclude, due to historical misconceptions that are very confusing and frightening, portraying a patient's age as an independent risk factors for surgery, some patients may not be receiving adequate treatment. Our study proved that although patients age over 70 years has significantly higher ASA scores and CCI score, there were no differences between that groups, and there were also no differences in the duration of surgery. Our presented data indicate that pancreatoduodenectomy should be considered in every patient with resectable pancreatic adenocarcinoma, regardless of age. And remember that the modern oncology should not know an age, and age should not be a limit. Thank you for attention, and feel free to ask some question.
Thank you very much, Jakub, for your presentation.
Thank you very much for your really beautiful presentation. Congratulations.
Thank you so much.
I have a question about your contribution to this work, and in your presentation you have pointed that BMI should be considered during qualification for operation. Could you explain how you...
Yes, of course. So it was my original project. That was my own idea for this presentation, according to this literature data, which I presented and at the beginning from websites from patients, which are very confusing, and I think that we need to publish this publication in order to specify an age during qualification. That age should not be independent risk factor.
And what about BMI?
Okay, maybe okay, so we have scientific proofs that BMI is that of bigger risk complications in patients with abnormal BMI, both too long in malnutrition and too high in obesity. And these patients cannot be completely disqualified from PD, but we think that appropriate management should be
so for example, nutritional support.
Yes, I think about preoperative nutrition support in patients with malnutrition, and about big awareness for possible post-operative complications in order to prevent them and to intervene as soon as it's possible.
Of course.
I would like to add also that about our contribution, we also made a statistical analysis and we participated in the surgeries of these patients, some of these, not all, of course. And about the BMI, preoperative nutrition care is important also in patients with high BMI because they also can be malnutrited.
Exactly. Thank you.
Okay, and to this contribution, I think we can safely say that we all prepared a database. Database is expensive, is extended, and we think that we will make more than one publication from this data.
Yes, our database are quite expensive, so I think that it would not be only one publication. And I would like also to add that operation.
Jakub, I'm sorry, we don't have enough time for all
it's
your
really important
sentence,
event, and patients should be well prepared. Thank you so much.
Thank you very much. Thank you, guys. And now, Jakub Minas will present for us his work about pancreatic neuroendocrine tumors, surgical treatment.
My name is Jakub Minas, and I would like to present our study, Pancreatic Neuroendocrine Tumors, the Surgical Treatment. So first, the background. Pancreatic neuroendocrine tumors constitute 30% of gastrointestinal neuroendocrine tumors, and the morbidity is still increasing. 60 to 90 pancreatic neuroendocrine tumors are hormonally inactive, so their symptomatology is poor. The preferred treatment for these tumors is the surgical resection of the tumor. Our material methods were the patients who underwent the surgery in Department of Gastrointestinal Surgery between June 2018 and December 2022. And all the patients had the pancreatic neuroendocrine tumor confirmed by the histopathological examination after the surgery. First, the age. The mean age was 56 years, and the youngest patient was 24 years old, and the oldest patient was 79 years old. And the group of men and women was quite similar. The comorbidities. The most common comorbidity was the arterial hypertension. I would like to say also that the thyroid gland, the thyroid gland goiter were also quite common. The characteristic of the patient, now the BMI. We can see the mean BMI was 26.61, the maximum BMI was 40.25, and the minimum BMI was 16.98. We can see that the most of patients had ASA score 2 and 3. And now the characteristic of the tumors. Most of the tumors were single, but 6 of these 65 was multiple. We can see, as the literature say, in our study was the same, most of them are inactive tumors. Now we know that there were 26 active tumors. Most of them secreted insulin, because it was 22 of them, because we can see there were 14 insulinoma, but 8 of insulinoma secreted also somatostatin or glucagon, or both of them. The localization was mostly body and tail. Usually it was together body and tail. And the mean diameter was 2.1 centimeter, but we can see they are quite different. The smallest tumor was the diameter of smallest tumor was half a centimeter, but the maximum was 6.5 centimeter. And now I go to the TNM scale. Most of tumors had Steve score 1 or 2. We can see that most of the tumors doesn't metastasize. Only 4 of them gave metastasis, and all of the metastases were in liver. Now I go to the type of surgery. Because of this localization, which I said before, the most of the surgeries were distal pancreatectomy, but we can see also that tumors located in the head of a pancreas were resected by a pancreatic duodenectomy. We can see that there were quite more different surgeries. The mean surgery time was 300 minutes. But we can see it is quite different for the surgeries. We can see that the enucleation of the tumor is the shortest operation. And we can see also that the subtotal pancreatectomy was the longest operation in its meantime. Now I would like more to talk about the distal pancreatectomy. We can see that 28 of 41 was presented also with splenectomy. And now I'd like to talk about the cholecystectomy, because when there was a pancreatic duodenectomy, it was also quite usual to do a cholecystectomy. Now I would like to talk about the operation, the complications. The complication rates was 40.76%. And we can also see that only 2 patients have stayed on intensive care unit, and there was also 1 death. The most common, I would like to talk about the complications by the operation. We can see that the pancreatic duodenectomy has the highest complications rate. The most common complication was pancreatic fistula type A. Okay. And there are also 8 reoperations of 7 patients because one patient has 2 reoperations. We can see that it was most usually necrosis, hematoma, and bleeding from the splenic vein. And the conclusions are the most common location of the pancreatic neuroendocrine tumors are body and tail. The most common surgery is distal pancreatectomy. The age range of these patients were 55 years, and the most common complication was the pancreatic fistula type A, which is not clinically significant. These are my references, and thank you. Feel free to ask the questions.
Thank you very much. Okay. Our jury, have you any questions?
Thank you very much for your very nice presentation. I have 2 questions. The typical, what was your contribution to this work? And the second question concerning the cholecystectomy. You showed that in some patients during the surgical procedure, cholecystectomy was also performed. Could you explain why?
Yes, so firstly, I will say about the contribution. We both collected data, and I made this presentation statistic and presented it here. And about the cholecystectomy, it is a prevention of cholecystialysis because the patients with neuroendocrine tumors are usually treated with analogs of somatostatin, and the analogs of somatostatin increase the risk of cholecystialysis. So the prevention of this this problem is due to cholecystectomy during the surgical operation of pancreas.
Exactly. Thank you very much.
We have some question here.
Thank you. I've got a question. Have you got any information regarding follow-up of your patients? Thank you.
We didn't do the follow-up already, but we are planning to do it. We know that 7 patients were hospitalized in our department. And we know also about the reoperations in our department, which I have shown before. So that's the follow-up what I already have. But I don't know if the patient wasn't hospitalized because of the complications in other hospital or something like that. So we didn't do already this follow-up.
Okay. So thank you for your answers. Thank you for your presentation. Okay, and now 9th presentation of our session will present by Arushi Chaurasia. I'm sorry. So please present.
Okay, so I would like to show you a presentation about colloidal cysts, and I'm a 3rd-year medical student, and I with Marta Kwiatkowska did a study on the surgical treatment of colloidal cysts in adults. The plan of our presentation is to give you a brief characteristic of colloidal cysts, and then I would move on to our study. So what basically colloidal cysts are? They are a very rare congenital disease, and they are characterized by a cystic dilatation of bile tree, and depending on the location of the deformation, we classify colloidal cysts as totally from 1 to 5. And what's interesting is the geographical location of seen cases. In West, it is very rare, but in countries such as Japan, it's more commonly seen. Now I would like to tell you about the classification. From the top, there is 3 types of type 1. The type 1 is characterized by dilatation of common bile duct. The next type is type 2. It looks almost like a duplication of gallbladder. Next type is type 3. It's called choledohotole. And next type 4, 4A, 4B are types with multiple cystic dilatations. Type 4A includes intra and extra hepatic dilatations, and type B includes only extra hepatic dilatations. There is also type 5, and the type 5 is Katowice disease. Moving on to the complications related to the dilatation, I would like to tell you about the pancreatobiliary reflex. It is caused by, usually in 80%, the reflux is caused by long common channel. The juice from pancreas and bile mix, and they can also cause mucosal changes in the wall of bile duct, and they can lead to cancer. Okay, thank you. Okay, so the aim of our study was to see how patients with biliary cysts are treated surgically, what types of surgeries are chosen, and what are the post-operative outcomes, and if there are any complications, and if they are common. Next thing we wanted to see is the symptoms that the patients presented. Our study was a single center retrospective study. We collected data from 2004 to 2022, and then we analyzed the clinical presentation, diagnosis, and treatment, and also the post-operative outcomes. The results that we were presented with was that it was more common with women. In almost 85%, it was only women, and 2 cases were men. The average age was 44 years. The clinical presentation showed that 4 patients were asymptomatic and the rest were symptomatic, meaning 9 patients. The abdominal pain was the most common symptom. It was present in 9 patients. 4 patients presented jaundice. 3 patients presented acute pancreatitis, and there was also some signs of nausea, vomiting, and diarrhea. And 7 patients were classified as Todani 1. 2 patients were classified as Todani 3, 4 patients were classified as Todani 4, 5 patients were classified as Todani 5. The surgeries that were performed are mostly primary surgeries. Only 1 surgery was secondary to the drainage of the cyst and biliary tract. 10 patients had complete excision of the cyst and Roy and Y hepaticojejunostomy with cholecystectomy. 1 patient had excision of anastomosis and common biliary duct with cholecystectomy. 1 patient had intrahepatic cyst excision with cholecystectomy, and also 1 patient had pancreaticoduodenectomy. Okay. The majority of evaluated colorectal cysts were symptomatic to any 1 type. They were mostly reported in women. The average age at presentation was 44 years. The surgical cyst excision with Roy and Y hepaticojejunostomy was the treatment of choice in most patients. And now I would like to answer any questions.
I'm sorry that I need to pause your presentation.
Thank you very much for a nice presentation. I have the first typical question: what was your contribution to this work? The second one is related to the comparison of your results, especially concerning the age and the gender of patients with biliary cysts. And the third question is about the histopathology. Have you found any dysplasia or maybe even cancer in the removed cysts?
So my contribution to this study was to collect data. Marta did the analysis, and you asked about the gender of the patients that were in our case, most patients were women, and as well it was almost the same in our other studies. And next question was about histopathology. So we had a little bit problem with histopathology, but we found few. And one of the patient had dysplasia, and it was documented.
Okay. So any other question from you guys? No? Okay, so thank you very much for your presentation. Okay, and now we go to 10th presentation today, presented by, I don't know, maybe Michał or Emilia. You will try, okay. So by Michał Serafin.
Na starcie chciałbym przeprosić za mój głos, mam zapalenie krtani, ale... Can I start? So, dear jury, ladies and gentlemen, my name is Michał Serafin, and today I'd like to present the evaluation of recent outcomes of endovascular treatment of carotid artery subocclusion as an alternative to surgical treatment. So what is carotid subocclusion? There is a clinical problem in identifying carotid near total occlusion, mostly due to the lack of diagnostic criteria and standardized imaging techniques. but in most cases it is defined as a 95 to 99% stenosis or a narrow caliber lumen with a trickle flow. And moving on to the treatment, there are two therapeutic options. One of them is endarterectomy, which is a classical surgical resection of atherosclerotic plaques from the lumen of the vessel. The second one is carotid artery stenting, which is endovascular technique. It involves in inserting a tiny catheter through the femoral artery to the narrowed carotid artery, and then inflating a tiny balloon to widen the lumen vessel. On the end, the small metal stent is placed. However, this treatment in subocclusion is still a matter of debate. Our hospital is one of the few centers in Poland performing this treatment in this disease. So what is the first line of the treatment then? The biggest randomized trials in North America and Europe showed that the benefit of endarterectomy increases with increasing stenosis severity. However, they only included they only compared endarterectomy with medical treatment and excluded near total occlusion. There is also a little data about safety and efficacy of carotid artery stenting in subocclusion, mostly small, non-randomized studies, because this treatment is still considered dangerous in this condition. There's also some technical problems. It requires operators' extensive experience to put the catheter through the such narrowed part of the artery. Considering all of this, the currently preferred treatment is endarterectomy. Therefore, our aim of the study was to evaluate the early risk and outcomes of endovascular treatment of carotid artery subocclusion. We performed a single-center prospective studies on the group of 29 patients. Immediately after the procedure and 24 hours after, the patient was asked to provide the subjective information about the pain in visual analog scale. The obtained data were supplemented and compared with clinical and imaging data such as a Doppler ultrasound and intraoperative angiogram. Moving on to the results, 8 patients had carotid artery subocclusion, which is 27.59% of the whole group. 4 of them were men and 4 of them were women, with the mean age of the 68.8 years. On admission, 6 patients had associated symptoms, and the most common was the history of the stroke. Here we can see a couple of intraoperative angiograms. Worth noticing is that the vessel lumen after stenting had increased a lot. The most common type of stent used was Siriguard carotid IPS in a total of 6 patients. The second one was Precise Pro RX. The median width of the stent was 7.5 millimeters and the median length was 35 millimeters. After surgery, the IC diameter increased to median 4.8 millimeters. During the operation, only 1 patient complained about the pain. However, its severity was 7 out of 10 on the VAS scale. During the postoperative period, all patients were pain-free. All procedures were successful. By success, we mean immediate revascularization of ICA. There was also no complications. Therefore, the in-hospital mortality and morbidity was 0. To conclude, despite the opinion that carotid artery stenting is contraindicated in this condition, endovascular treatment of carotid artery subocclusion may be one of the therapeutic options. It is characterized by the high procedural success rate and a low complications rate. However, it requires operators' extensive experience and constant monitoring of patients in peri and postoperative period. Thank you for your attention. Do you have any questions?
Thank you, Michał, very much.
Thank you very much for your presentation. Thank you for your participants and presence here in the, within this is. I have some questions. The first one is typical. What was your contribution to this work? The second one is about the decision concerning the qualifications to the operation, because we know that we have two kinds of surgery, intravascular and open ones, your patient maybe were some such called the high-risk patients for open surgery. What was the reason for qualification to the intravascular procedure, not open one? This is the second question. Who decided about it? What about the neuroprotection? All these procedures were performed with neuroprotection. If yes, what kind of neuroprotection was performed? And what the technical access to the internal carotid artery?
Okay, so my contribution, firstly, we assist in some of these surgeries. We also ask the patients about the pain after the procedure and after 24 hours. And also we obtain all of the data and prepare the presentation. And
what about the qualifications to the kind of operation?
Qualifications.
What indications were for the carotid artery stenting, not opened carotid endarterectomy?
There's a problem in diagnosis of subocclusion, because in Doppler ultrasound, it's often often indicates lower stenosis, not 95 or more, but 90 or even 80%. So all patients had before the surgery had Doppler ultrasound, and no one had 95% or more stenosis. But during the operation, after the arteriogram, arteriograms showed that it is a subocclusion. Our professor decided to perform the surgery.
Because I'm asking about it, because we can distinguish some indications, some factor that decide about the qualifications of patients for the stenting, not carotid endarterectomy. For example, after negradation or when the stenosis is location very highly in the internal carotid artery. Were there such situations in your patients?
No, as I say, the most common form, the most common qualifications criteria was Doppler ultrasound and patients.
I think it has depended on the surgeon.
Yes, and patient's overall condition, because endarterectomy is open surgical resection, so it's more. It is for patients. It's more severe operation than stenting.
For example, severe general condition. Yes, it's also because the stenting is performed without general anesthesia. Yes.
Yes, it's.
And the hospital stay is shorter. The duration of procedure is also shorter compared to the open surgery.
Yes.
And what about neuroprotection? Do you know?
Yes.
Kind?
There was standard classical neuroprotection with a spider X.
What is the kind of neuroprotection? Because we can distinguish proximal and distal ones.
It was distal.
Yes, of course. Distal. And the axis?
Through artery? Through the femoral artery.
Thank you very much.
Just one short question, because we established that probably the surgeon decided about the type of approach. Were these surgeries performed by one person or different surgeons? Because there are
one person.
8 patients. One experience.
One surgeon.
Thank you.
Thank you very much. Okay, so now we have only 3 presentations left for today's session of surgery. And now please welcome Michał Serafin, I'm sorry. Alexandra Tobias will present for us the presentation about pancreatic post-inflammatory cyst surgical treatment.
Dear committee members, ladies and gentlemen, my name is Alexandra Tobias and I'm here to present our study, Pancreatic Post-Inflammatory Cyst Surgical Treatment. What are pancreatic pseudocysts? This term describes a peripancreatic, or much less commonly an intrapancreatic fluid collection surrounded by well-defined wall that contains no solid component. It occurs more than 4 weeks after an onset of interstitial edematous pancreatitis. And here we can see contrast-enhanced computed tomography criteria and a CT scan of pancreatic pseudocyst. There are several methods of surgical treatment of pancreatic pseudocysts. Active observation may be used in asymptomatic cysts. They can be treated endoscopically by cystrogastroduodenostomy, and there are several surgical methods. In our study, we focus on 3 of them, which are pancreatocystogegenostomy, marsupialization, and external surgical drainage. And now I will briefly explain what these methods are all about. Roux-en-Y pancreatocystogegenostomy consists in anastomosis of the pancreatic pseudocyst with the small intestine. The small intestine is cut in one place, and then the distal end is sutured into the lumen of the cyst, while the proximal end is sutured below the anastomosis. Marsupialization is a technique of cutting a slit into the cyst and then suturing the edges of the slit to form a continuous surface from exterior to interior surface of the cyst. So sutured in this fashion, the site can remain open. And the last method is external surgical drainage. In this method, a catheter is placed through the skin to drain the cyst. Let's move on to the aim of our study. The aim of the study was comparison of indications, quantities, and outcomes of different types of surgical treatment for pancreatic post-inflammatory pseudocysts. We performed a retrospective analysis of 18 patients, 14 men and 4 women. All of them were treated surgically for PPCs, which are pancreatic post-inflammatory pseudocysts, in the Department of Gastrointestinal Surgery between January 2012 and December 2022. We collected data about cyst size, type, risk factors, and complications of the treatment, and we also made a follow-up using data from Gastrointestinal Surgery Clinic. Most of our patients were assigned to the 2nd category of American Society of Anesthesiology scale, which describes a patient with mild systemic disease. Most of our patients were asymptomatic, and among symptomatic patients, the most common symptom was abdominal pain. All of our patients, before they were diagnosed with pancreatic pseudocysts, had chronic pancreatitis or acute pancreatitis in their medical record. Pancreatic pseudocysts were most often a complication of acute pancreatitis in 77.8% of patients. In 5.6%, it was a complication of chronic pancreatitis, and in 3 of our patients, acute and chronic pancreatitis overlapped. The most common cyst localization was the body and tail of the pancreas. The largest cyst size in computed tomography was 300 millimeters, and the smallest one was 100 millimeters. The most common method of surgical treatment was Roux-en-Y pancreatocystogegenostomy, followed by marsupialization and external surgical drainage. All of the performed procedures had very similar duration time, on average between 150 and 160 minutes. Duration of hospitalization was the shortest in patients treated by Roux-en-Y pancreatocystogegenostomy compared to marsupialization, and also the duration of hospitalization after the surgery was the shortest in patients treated by Roux-en-Y method compared to the other 2 surgical methods of treatment. In-hospital mortality was 0%. Complications occurred in 3 of our patients, all following pancreatocystogegenostomy, and the complications were abdominal fluid collection, treated conservatively, pancreatico-mediastinal fistula, treated by Roux-en-Y pancreaticogegenostomy, and retroperitoneal abscess, treated by surgical drainage. Cyst recurrence was observed in 2 cases. Both of them happened after external surgical drainage. One of them was diagnosed 1 year after the surgery and was treated conservatively, and the other one was diagnosed 199 days after the surgery and was treated by cystrogastroduodenostomy. In the remaining cases, the cyst size was reduced and a therapeutic effect was achieved. Let's move on to the conclusions. Roux-en-Y pancreatocystogegenostomy was the most common type of the surgery, and it was associated with the shortest duration of hospitalization. The post-operative morbidity rate was low and mortality rate was 0. Thank you for your attention. We will gladly answer your questions.
Thank you, Alexandra.
Thank you very much for your very nice presentation. Congratulations to your beautiful drawing.
Thank you very much.
I have the typical first question is concerning your contributions to this work. And the second one is about the, do you know what is the less invasive alternative recently more and more frequently used in the treatment of post-inflammatory pancreatic pseudocysts?
So about our contribution, we all collected data to this presentation. One of our colleagues made the statistical analysis, and I also prepared the presentation.
So the most common operation in this case is endoscopic pancreatocystogenostomy, but in our case is surgical.
Thank you. And do you know the conditions to perform the pancreatocystogenostomy? Technical conditions?
Yes,
when, for example, we perform the pancreatocystogenostomy, where only the drainage, simple drainage.
To perform
it depends to the
pancreatocystogenostomy. The cyst wall must be thick enough to perform the the cyst wall must be thick enough, and it must be located in the proximal part of the pancreas to perform the pancreatocystogenostomy.
It depends on the thickness of the wall, yeah?
Yes.
Because when the wall is thin, we can't perform the anastomosis between the pancreatic cyst and the jejunum.
Maybe one question. Do you have any data? I'm not sure whether we presented it, whether the patients were all operated on as planned surgeries, or were there any surgeries performed due to, for example, hemorrhage?
Yes, planned surgery was the most cases. It was 12 of them, and 6 of them was the urgent cases.
Anybody have any question? Okay, so thank you guys very much. Okay, so now 2 presentations left. And now please present the presentation about the results of surgical treatment and long-term survival of patients with ambulatory adenocarcinoma.
And long-term, yes, adenocarcinoma.
I'm sorry.
Exactly.
Okay, please.
Thank you. It's a pleasure to be here once again. So I would like to present the results of surgical treatment and long-term survival of patients with ampullary adenocarcinoma. As we know, ampullary cancer is relatively rare neoplasm, accounting for 2 to 5% of all gastrointestinal tract cancers. And as I mentioned before, only surgical treatment can ensure radicality. And in patients with 4th stage of cancer, the 5-year survival without this treatment is close to 0%. The aim of our work was to analyze the outcomes of surgical treatment of ampullary adenocarcinoma, especially in terms of post-operative complication, 30-day mortality, a 0 resection rate, which means preservation of surgically clean margins and long-term survival. So out of this 389 patients undergoing pancreatoduodenectomy between 2016 and 2021, we extracted 102 patients enrolled in the study. We focused especially in this study on follow-up, which was conducted by telephone interview and by analysis of the data from hospital research. Also, clinical data, including the perioperative course and histopathological findings, were obtained retrospectively. Among, as you can see on that chart, among 102 patients, 41 were women and nearly 60 were men. The mean age of the patients was 68 years, so this is elderly population. And according to the ASA scale, operative, most patients were classified as class 2. In nearly 70% of patients of causes jaundice occurred, and that group of patients required biliary stenting. In 3 patients, we also observed the tumor recurrence after endoscopic ampulectomy. So let's see on surgical treatment. Majority of patients had pancreatoduodenectomy using Traverso method, following the Whipple method at Flautner method. The mean duration of surgery was 430 minutes. And one procedure performed by us was palliative, and the indication was an active bleeding. As you can see on that table, early surgical complication occurred in 40 patients, and most common, as you can see, in 11 cases were pancreatic fistula and intra-abdominal fluid collection, respectively. Severe complication occurred in 70 patients, and also there were 10 reoperation due to pancreatic fistula, post-operative acute pancreatitis, biliary anastomosis leakage, abdominal abscess, post-operative wound dehiscence. The in-hospital mortality rate was nearly 8%. It occurred in 8 cases, and as you can see, the most common cause in 3 cases was the sepsis due to biliary leakage. In rest 2 cases, it was a result of superior mesenteric bleeding. As you can see on that histopathological results, the R0 resection rate was achieved in 87% of patients. The mean number of removed lymph nodes was 28, and there were also 38 patients with N1 stage and 35 patients in N2 stage. The tumor with stage P3, PT3 and 2 were the most common. As you can see here, in 16 patients, we observed the progression of the lesion in relation to the result of diagnostic endoscopy. Now I would like to draw your attention to follow-up of our patients. Out of 94 patients discharged discharge from the hospital. Survival data we obtain in 88 cases. At the time of the follow-up, which was 3rd of April this year, 63 of them were still alive. And we also made a survival estimation using Kaplan-Meier method, and median survival time was 28 months, and 5-year survival rate was 66.1%, and a little bit higher 3-year survival was 70.3%. To conclude, pancreatoduodenectomy is the method of radical treatment for ampullary adenocarcinoma, and as I mentioned, it can only ensure the radicality of treatment. Early surgical complication and severe complication occurred in our patients in acceptable number of cases. Although a majority of cases were advanced, the 3-year survival rate was 70.3. That can correlate with the literature data. Thank you for attention.
Okay, thank you very much again. And I remind you that we have only 3 minutes for discuss.
Okay.
Thank you very much for your next beautiful presentation. I have the first question is typical concerning your contribution to this work. The second is, have you compared your results with the literature data? And the third is about the survivor. What about the disease-free survival? Have you checked it?
Thank you so much. So my contribution was to invent with Carolina the subject of the study, and also to collect, we also collected data, make a statistical analysis, and took part in operation and taking care of patients. Yes, would you like to answer?
Your results? Yes, we compared the results, and results of survival were similar, but for this moment we can tell that most of patients, 62 patients, survived 1 year after the surgery, and the rest is estimation. We must wait about 2 years to tell you about the 3-year survival for sure, because this is only estimation. And the data about the complications were also similar. It was acceptable level of pancreatic fistula and other complications, similar to the literature data. And the last question was about the disease-free survival. So we are now during the estimation of disease-free survival, because this overall survival was partly from telephonical interview and partly from hospital data. Some patients did not answer our telephones, but we are going to retry the attempt of telephonic interview, and for now we don't have enough follow-up percentage to show disease-free survival. We have 95% of information about overall survival, but only 80% of disease-free survival information.
So we can say that the collection of these data is in progress.
Yes.
I don't know, because maybe I missed the data listening, but what was the preoperative diagnostics? Did all patients have histopathology prior to surgery, or maybe some of them had surgery before, like ampulectomy, which turned out not to be a benign disease, and they were reoperated on? Do you have this data?
Okay, yes. So some of them exactly has ampulectomy prior to histopathological results.
How many? Because it's interesting for me.
6 patients had endoscopic ampulectomy, and 3 patients had surgical ampulectomy, if I remember.
And then it turned out that they had cancer and had to
yes, and there was also one interesting case, which was that during the surgical ampulectomy, it was intra-examination and there was no cancer, but in the full examination after, Then after a month, there was a cancer, so the patient had also pancreatic duodenectomy.
Thank you.
Thank you very much. Okay, and the last presentation today of our surgery session will present for us Izabela Powalacz.
Good morning. My name is Izabela Powalacz. I'm a third-year medical student representing Jagiellonian University. On behalf of my team, it would be an honor for me to present our study under the title Impact of Abdominal Wall Thickness and Visceral Fat in Assessing Surgical Difficulties. To begin with, it is known that in every field of surgical medicine, patients with increased BMI increase the difficulty of laparoscopic surgery. It is confirmed by a large number of studies. Here I presented examples found on PubMed. All these studies were conducted on a normal population, which is important. That leads us to the statement that bariatric surgery is a challenge. Nowadays, high body mass index is one of the main predictor factors for intraoperative difficulties. Now, please pay attention on these two patients. Imagine they have the same BMI. From the first glance, you can notice that they differ in fat distribution. So, thinking that way, we ask ourselves these questions, the same question that I'm asking you now. Would this patient have experienced the same degree of technical intraoperative difficulties? Is it possible to find a more accurate predictive factor? In order to answer these questions, and because to date there has been no study looking for factors associated with difficulty in performing surgery in population of bariatrics only patients, we decided to conduct this study. We performed a correlational study based on 56 patients. We collected data during 3 steps presented here. At first, we collected the predictor variables such as gender and age. During the USG measurements, we used a convex transducer and applied it on the midline of the body, halfway from the cisternum and umbilicus. Here is an example of wall fat thickness measurement, which is marked. I don't know if it's from here to here. Another factor we gathered was from the tinnitus measurements. As you can see, it measures a lot of factors, but for us, the important one was visceral fat rating. All of our patients had a scheduled LSG procedure. The purpose of the LSG is to remove 85% of the enlarged stomach. But we needed to know if the LSG includes intraoperative difficulties. The main distinguished factor was the length of the surgery. But however, not all operators have the same experience. That's why we calculate the average time of each operator, and only this factor we compare to the length of the surgery. We divided our patients into 2 groups based on intraoperative difficulties. And now I want to describe the results. On this slide, the population's characteristic is summarized. As you can see, these groups did not differ in any of these factors because each P is above 0.05 in the table. That means that these factors were not statistically significant. What is important, our study finds that among bariatric population, the increase of BMI does not correlate with increase of intraoperative difficulties. Yes, and this is a preview of results of statistically significant measurements. We understand these results in a way that the patients with difficult surgery have a high level of visceral fat rating, which is the main factor, and consequently thin wall thickness. Here is a graphic presentation of our results, which stand out to be statistically significant. I would like to end emphasizing the main conclusion. Although the many researchers which highlights among normal population, which highlights the importance of body mass index in predicting intraoperative difficulties. Our research found that not BMI is the main predicting factor, but patients' fat distribution. Thank you, and I'm happy to answer the question.
Congratulations, thank you, and start the last to discuss.
Thank you very much for your nice presentation. The first question is typical. What was your contribution to this work? And the second one, I ask you to tell something more about the qualification of patients to the compared groups. What were criteria, included objective factors for the so-called difficult surgery?
Okay, so about my contribution, I performed USG measurements from patients and also made a database. About that, the other questions, maybe I can go through this slide. These patients with group with difficult, I mean, first of all, our patients were included to the study if they're after meeting the infusion criteria, such as they have had a scheduled LSG procedure, they adults, and they signed a consent, informed consent. But about the group with difficulties surgery is about that they have the longer surgery than the average time of the operator of this surgery.
Were all the procedures were performed by the same surgeon?
No, that's why we made an average, the average time for each operator, and then to each operator we like compare it if it's longer or equal, and the other group is shorter or equal.
Thank you.
And did you check for any other reasons for prolonged surgery? Because we can imagine that obesity, like the type of obesity, may change the type of access maybe to the abdomen, but maybe some intra-abdominal reasons for prolonged surgery could also cause longer time, but would not be directly,
To be honest, we just focused on this factor.
Okay, so you didn't ask or do any questioning of the surgeon about other complications during surgery? No.
No.
Okay, thank you.
Thank you.
Anybody have an answer? Oh, we have a question.
So I just want to ask, is there any upper weight limit above which the surgery is not performed? Thank you.
No, not really. Not really. To be honest, we have it's like the lever is from, to increase, not like this.
I'm sorry, we don't have time. Thank you very much.
Thank you.
Okay, and finally, all the submitted papers have been presented. We congratulate all of the presenting authors and participants of the surgical session. And at this point, I would like to ask the president of the jury, Professor Beata Jabłońską, for a few words to sum up the session. We have someone who needs English language. Oh, we have
I would like to thank everybody, all of you, for the participants in this Congress. All presentations were really very good, but we had to choose the winners today, and I would recommend all of you to work more and more and to publish your results in future in journals. And I wish good luck and achievement of your scientific goal in the future. Thank you very much.
Okay, thank you very much for those words. And thank you, of course, the doctor. Now we would like to invite all of you to workshops during this year's conference. You will find all the details on the website simc.sum.edu.pl. And we would like to also invite you to the decoration and closing ceremony of the SIMC 2023 conference, which will be held in A3 Hall on the 19th of May. And I would like to thank you all for your presentation, and have a good day. Thank you.